Good morning. This is Lisa McBride, professor of NUR160. We're going to be going over your uh, week 2, lecture 2, mobility. As nurses, we definitely need to be familiar with the interventions to promote mobility, especially in those patients that for some reason may be immobile for just a short time or they're permanently immobile. We need to prevent them from having complications related to immobility, such as pneumonia, stiffness, inability to move their extremities, etc. Mobility is defined as the purposeful physical movement, including simple movements, that fine motor movement that we have in our fingers that allow us to pick up items and to write and to do things like art and hold on to things. Mobility is dependent on the synchronized efforts of our skeletal system and nervous system. And those systems are dependent on having adequate oxygenation, perfusion, and making certain we have nutrition that it supports our muscle strength. And of course, cognition, the brain. We need to have a ability for our brain to control those movements. Mobility requires adequate energy. So we did talk about nutrition. We have to have that protein and enough food stuffs so that we can make certain that we have what we need to keep ourselves healthy and well. The interrelated concepts related to mobility are quite a few. As you can see, there's our intracranial regulation, which is our brain. Again, nutrition, pain, gas exchange, making sure we have plenty of oxygen, and perfusion, which is getting that oxygen from our lungs to our various body parts and cells. And our mobility depends upon our tissue integrity and our ability for elimination of waste and products. So people that have problems with their brain and intracranial regulation, they become immobile because of unsteadiness, imbalance. They may have some vestibular issues with their ears. And individuals who are immobile may be unable to purchase, prepare, or consume adequate nutrition. So it's very important that we're supporting them in that effort. Malnutrition can lead to muscle wasting. Back in the 1700s and 1600s, our sailors learned real quick that they needed vitamin C to keep from having a condition called rickets, which was a bone debilitating and muscle wasting type condition. So we know that we need a good balance of nutrition coming from many foodstuffs so that we can make certain that everything is staying in good working order. A person with chronic pain may limit or interfere their ability to be mobile. They may not want to walk or to move because of the pain. But with some pain, like osteoarthritis, we'll be learning about, with movement, it becomes easier. So movement is a good thing to kind of loosen up, get the flexibility going, and being able to move. Some conditions like having a fracture or having surgery where we replace the hip or the knee can be very painful, but again, trying to keep the person as mobile as we can, whether it's upper body or lower body, is very important. If we don't have enough gas, perfusion, oxygen going to our different body parts, then of course we have an issue with oxygen wasting, but then those muscles are not going to work. We have a higher risk for venous clots because of stasis. The person's not moving, therefore that blood may clot, causing clots in the lower legs or extremities. If they have extended pressure on any body part, bony prominences, that reduces the perfusion of those areas. And so oxygen is not getting to their sacrum, their hips, their elbows, their heels. So we need to be looking at those. And then for those patients who are immobile, they may have changes to their pattern of elimination or be at risk for experiencing problems such as constipation and urinary retention. And that can also lead to further discomfort and reduced appetite that can have negative impacts. So diseases related to mobility, again, we have inflammation of the joint. Inflammation is heat, redness, swelling, pain. So we're going to see that when we're doing our assessment. There are two types of immobility we're going to talk about today, and that's osteoarthritis and rheumatoid arthritis. They have different characteristics. They have different things that cause them. Osteoporosis, of course, is the skeletal wasting where the bones become more brittle. That is more seen in older women and is characteristic of low bone mass. So it's very important to keep us moving, keep our bones healthy, make sure that we're getting calcium, vitamin D, and phosphorus. And then another condition called gout. It's a form of arthritis that's caused by uric acid buildup of crystals into the joints. It's very painful, and it is an inflammatory process. So osteoarthritis is the most common form of arthritis. It affects millions of people worldwide. As we, if you remember your bone anatomy, we have our bones, we have the joints, and we have between the joints cartilage. Cartilage is the cushions that help protect our bones from being worn down. But over time, that cartilage becomes thinner, less, and of course, cartilage doesn't have its own blood source, so it can't repair itself as easily. So when it's gone, it's gone. And then we have bone on bone, and then of course, osteoarthritis is the deterioration of the bone on the bone surface, and then to fix that, sometimes we have some old palliative type care that we can do, such as NSAIDs, anti-inflammatories. We can do some injections and things like that, but those are not permanent. And then the treatment of that when it becomes end stage basically is to do a total joint or a replacement of that bone. It most often affects the joints that are most used, which is going to be your hands and fingers, toes and knees, hips and spine. So getting stiff in the back, etc. Obesity is the major cause of OA, so we're putting on too much weight on our hips and our knees and our joints, and therefore to prevent this, you can actually cut down, but we still have thin people that end up with osteoarthritis. And so OA is usually noticed by the time we reach our 50s and 60s in both males and females, but by the time they're in their 70s, women have more problem than men do. It's that repetitive use of joints over the years causing damage to the cartilage that leads to the joint pain and swelling. Here's a picture of osteoarthritis as is related to aging. Again, the water content of the cartilage increases and the protein makeup of cartilage degenerates. And so we end up having the bone defect. Once the cartilage is gone, then our bones try to protect that or to fix it by growing more bones. But unfortunately, sometimes they actually cause more damage because it's building bone spurs or we're having nodules, we're having areas that are uneven. You may see pitting of the bone when you look at the x-rays, etc. Osteoarthritis is degenerative. It's non-systemic, non-inflammatory joint disease. So that means that it's not caused by our body attacking itself. It's just wear and tear. So there's two different forms of osteoarthritis. Primary, the cause is unknown. It's just basically getting older, being used. Of course, we know that obesity worsens it. Secondary is caused by trauma. It could be trauma because you fell from a tree from a height or you fell off a ladder, infections, previous fractures. And if you have rheumatoid arthritis, then it can cause you to also have osteoarthritis or stress on the weight-bearing bones. What happens most common is to athletes, they're overusing those joints. Risk factors for osteoarthritis include smoking, lack of nutrition, physical activity that's very high impact, exposure to carcinogens, genetics, and there's some racial and social disparities where we see it more often in some age groups, et cetera, and races, ethnicities. Again, primary, the cause is unknown. Secondary, again, we've already talked about the wear and tear and the constant abuse of the bone. Osteoarthritis also has two defining conditions called Herbert's nodes and Bouchard's nodes. Herbert's nodes are small bony growths that appear on the joints closest to the tip of your finger, so that's the distal area of your finger, whereas Bouchard's is most likely seen in that middle to the ones closest to your knuckle. It is a swelling bony outgrowth. Sometimes, again, it can be because of some trauma, breaking the finger, breaking that area of the joint, and it causes those bones to grow little bony outgrowths. It can restrict the movement of the fingers or limit some of the grasp that the patient may have. Osteoarthritis signs and symptoms, again, is pain upon awakening in the morning. It's worse usually, and stiffness, but once they get moving, sometimes the stiffness may help kind of get out of there. They get more flexible. Uh, Being active is very important. They'll have tenderness in that particular joint. They'll have some loss of flexibility, may not be able to bend down to reach something or stand back up. They have a grating sensation. Again, that's that bone on bone. And you may see in x-rays and CT scans bony spurs, projections along the bone edges. And of course, swelling and heat in that joint may occur, as well as some fluid. There are no really blood tests for osteoarthritis. There are some tests that can actually rule out that it's caused by something else, such as rheumatoid arthritis. We can do joint fluid analysis, especially if we think there might be some infection or if we think there might be gout in the area. For gout, we can do a uric acid analysis with your blood and see if it's above 9.0. And if it is, then we know that remember your normals is per the lab that you use. But if it's high, then we can put that person on some medication that will help with gout. Sometimes they use steroids, etc., for an acute flare. Again, medications for osteoarthritis. The normal treatments are a little bit of Tylenol. Helps with mild arthritis. NSAIDs, but we have to be careful with NSAIDs. Again, non-steroidal anti-inflammatories such as Aleve, Motrin, naproxen sodium, aspirin, and your ketoprofen, etc., are all contraindicated in patients that have a worry about GI bleeds or in the elderly. We want to make sure that that you're taking NSAIDs with food or with some milk to coat the stomach. We want to make certain that they're not on a blood thinner because, again, NSAIDs are going to make the blood much more thin. So if they're on warfarin, NSAIDs are contraindicated. Another medication that is sometimes used with osteoarthritis is Cymbalta. It's actually used for suicide and depression, but it can also help with osteoarthritis or pain conditions. It just depends on the person. We need to monitor their sodium level and liver function test before starting Cymbalta. Ambulation, it's good for these people to walk, to keep flexible, to make sure that they have good supporting shoes. They can use orthotics to help with the foot. Use canes, crutches, or even walkers just to keep them as mobile as possible. And then there are some non-traditional treatments out there. We can use arnica, which is a gel. We can use also biofreeze, other topical agents for osteoarthritis relief. Sometimes a doctor may prescribe Voltaren, which is a topical ointment used as prescribed, though, or for package directions on those. And then also there are some injections that are also being utilized. We have hyaluronic acid. We also have steroids that can sometimes be used in order to cut down on inflammation. And then there's also ozone with herbals that are sometimes being used by interventional medicine. It is showing quite some good promise without any side effects. Osteoarthritis nutrition, make sure that the patient is getting a good, well-balanced diet. There are certain foods that the American Association of Arthritis has said that is worse. So we try to tell people to avoid omega-6 fatty acids. Don't eat a lot of sugars or sugar alternatives because it can actually worsen arthritis. To limit their red meat, fried foods, not to use so many refined carbohydrates because those our bodies will turn to fat a little bit faster, and to watch how much cheese and high fatty diet, dairy, and alcohol that they're using. The good diet things they should be eating is oily fish such as salmon. Omega-3 fatty acids are good for us. They have some anti-inflammatory properties. Some patients also take fish oil capsules for their arthritis. So we have oils like olive oil, avocado oil that are good for you. Dark leafy green vegetables, broccoli, green tea, garlic, and nuts have been shown to help with a little bit of the arthritis. Rheumatoid arthritis, however, is again an inflammatory process. It is thought to be due to immune factor or autoimmune disease, which can affect people of any age. We do have juvenile rheumatoid arthritis, so it is characterized by chronic inflammation of the joints. Rheumatoid arthritis can also involve inflammation of the tissues in other areas of the body, such as the lungs, heart, and eyes. Because it can affect multiple organs of the body, rheumatoid arthritis is called a systemic illness, meaning that it can hit anywhere and everywhere. Rheumatoid arthritis is chronic. People may experience periods without symptoms, and then they'll have continuous symptoms also. It's a chronic systemic crippling disorder characterized by that inflammation, damage to the joints, and when the damage to the joints occurs, as is demonstrated in this photo on the slide, eventually we get to where we're bone on bone, and the bone trying to heal itself and trying to repair will cause it to fuse. And so we end up with loss of elasticity of our use of our hands and our feet and our legs and stuff, and they'll have deformity of those long bones because of the rheumatoid arthritis affecting those areas. Again, lung, heart, and blood vessels, muscles, eyes, and skin can all be impacted by the rheumatoid arthritis. Key points about RA include to look at the symptoms of the RA. What are the symptoms? If you think back to the patients that you've taken care of that have rheumatoid arthritis, of course, they're going to have pain, stiffness, they're going to have reduced range of motion. They're going to be having harder time pulling on socks or reaching for things or holding and opening bottles, etc. And so it's going to affect a lot of their hands and feet. People that play the piano aren't capable of playing the piano any longer because their fingers are so stiff. So they also have other symptoms like fatigue, stiffness preceding their joint symptoms. They may have blood work that will show that they have the RA factor in their system as well as the anti-CCP antibodies. No cure exists, but we do have some management factors that we can use. Again, NSAIDs, corticosteroids, and then your anti-rheumatic drugs like DMARDs. Now, your DMARDs, I would tell you to go and Google those. DMARDS. Again, that means disease-modifying anti-rheumatic drugs. Those also include things like methotrexate. They include some of the antimalarials. It also includes the MABs, so the immune-modifying drugs that have been newly coming onto the market quite quickly in the last 10 to 15 years. The NSAIDs, of course, inhibit the inflammation. We have COX inhibition, COX-2 inhibition that is cutting down on the inflammatory process. We can use Tylenol and other analgesics to help with managing pain. Again, you've got to remember that not all patients should be using NSAIDs, so sometimes our treatments are limited in some people. We want to make certain that we watch for fever with these patients because with flares, they can have a fever. And again, always ask your rheumatoid arthritic patients if they're taking a disease modifier. You're going to know that when you look at their list of meds because it's going to be with some of those strange issues and those strange medications that you don't see very often. Definitely because they're on NSAIDs. We need to watch for GI bleeds. We need to watch for GI issues. Do they have blood in their stool? Are they having stomach pain with eating or after eating? Rheumatoid treatment again. Regularly evaluate their pain, location, severity, frequency. Assess for joint tenderness, swelling, heat, inflammation in those areas. Ask them to track their progression, any thing that makes it worse or better. Encourage them to participate in therapeutic exercise, gentle range of motion. Tai Chi is always wonderful, low impact. Even swimming pool and walking exercises in the swimming pool is great because that's warm water, usually in most places where they can do that. Teach simple protective techniques. Make sure that they're wearing appropriate shoes. They can use some joint splints. A little bit also with their clothing that they cannot button buttons or zip zips. Sometimes pullover clothing that pulls up that has elastic to it so that they can dress much more easily. Shoes that they can just slip on that uses Velcro for ties instead of having to tie their shoes. Psychological support, yes, they may have some increased depression. They may be feeling isolated. They may feel kind of sad about their lack or ability to do the things they did when they were younger or when the disease was not affecting them. If they're young, they're really going to be impacted by this because they're not going to be able to participate in sports and things that other people their age group are doing. So teach the patient about their medications and use, put them in contact with tertiary prevention groups such as the Support for the Juvenile Arthritis groups and walking groups. Look at the social support groups that are in your area. Okay, let's move to fractures. Different types of fractures. We're going to be discussing this in lab in a little bit more detail, so I'll go over this pretty quickly, but I want you to get the concepts of the fracture down so that you understand the differences. Complete fracture means that bone is completely broken all the way. Incomplete just is exactly what it sounds like. It means that it's broken partially, but not through the entire bone structure. It can be open. What that means you can see the bone, it's through the skin. Compound means it's multiple places under the skin. You won't see that. Closed, of course, that's closed or simple. So we want to know that we have a closed fracture, and a simple closed fracture is a bone that's still well approximated to itself and is still within the skin and the muscle. We can also have pathologic fractures that's due to cancer. It can be due to infections, etc. We can have stress or fatigue fractures. That's from overuse mostly. If you have a cross-country teenager that's running cross-country and that continued pounding and they're complaining of foot pain, they probably have a stress fracture. They're going to need to rest their feet, make sure they have proper shoes, proper socks if they're being evaluated. A stress fracture or a fatigue fracture typically does not show up on the x-ray soon after it happens. They may have to do a CT scan or a bone scan in order to see those type of fractures. Compression fractures are those fractures that happen, for instance, in our vertebrae. It's cracks in the vertebrae as we're walking, or it's basically the weight of the upper part and the lower part coming together and breaking the bone because the bone is brittle. Compression fractures, there's not much things that we can do about that except just rest, letting them heal. They can be quite painful and debilitating, especially in the older population. Here's some examples of common types of fractures. Again, in picture form, we have a closed, non-displaced, open compound, meaning that you're going to have to reduce that. You're going to have to put it back in the bone, put it back in the arm or the leg or wherever. Comminuted means many fragments, many pieces, and that's typically from crush injuries. Displaced, meaning that the bone is just not where it's supposed to be, so it needs to be put back where it belongs. Oblique is going through the bone in an angle. Spiral fractures, those are not good. Those are the fractures that are opposite mechanics are acting on the extremity. So typically those are twisting movements. Of course, you see that with abuse sometimes. And these can be also without abuse. They could be the kid that's swinging from the monkey bars at school. They get their hand caught between two pieces and they twist their body around their arm and it pops. So check with the child, check with the adult, check to see what the story is on how they broke that, and it'll explain why the fracture looks the way it does. Impacted, of course, that's the force coming down or up. You fall forward and you catch yourself with the palms of your hands and you fracture the bone. That becomes an impacted fracture because you're pushing the bones one against itself. It's going to have to give, so it fractures. Green stick typically occurs in our young. If you have a periosteum that goes across the bone, it is very flexible. Um, in children, their bones are a little bit softer. They're not as hard or formed. And when they break their bones, sometimes they'll get a fracture on one side, but then it'll bend on the other, but not completely fracture through. So that's your green stick. Here's another example again: transverse, linear, oblique, etc. Spiral, green stick, comminuted. If you see a patient with a femur, and this happens to be a femur fracture of the long bone, if they have that fracture that is like the transverse one that's there, they sometimes put a nail down through the two parts in order to pull that back together. Um, so it's quite interesting. You can find those procedures on YouTube if you're interested in looking at one of those. After our fracture care, we have 5 phases of healing. The 5 phases include hematoma formation. That's immediately after the fracture. Blood vessels will break and form a blood clot or hematoma around the fracture site. Within 48 hours, we're seeing some inflammation. As blood flow increases, it's our body's response in order to try to heal, try to get rid of the debris that's around the fracture. So white blood cells and macrophages will go to the area to start cleaning that out. So we'll have some inflammation, swelling. So it's not a bad thing unless it's too much. Then after the bones come back into approximation with one another, we'll have a soft callus formation of fibroblasts, collagen fibers, trying to heal that fracture site. And then we get hard callus formation, osteoblasts invade the area and begin to form the new bone, creating a new hard callus or bone bridge. Once that bone has been healed across, then we get bone remodeling, meaning that our osteoclasts go back in there and reform. Now, that person will always have a thickened area of bone, even for years to months, years later. You can tell that there was a fracture in that area. Bone healing is affected by nutrition, disease, and our aging process. Usually, most fractures heal within 3 to 12 weeks. The older the person is, the longer it takes for them to heal. Nurses caring for older patients should also provide care, make sure that they're getting their pain medication, analgesics, Tylenol, Narco, if that's appropriate. Make sure that they're using the appropriate assisted devices, that if the doctor has told them not to put weight on an extremity, we have to make certain that they have the correct wheelchair, walker, crutch, or cane. If they can put care, then we're just going to make certain that they're using it correctly. Monitor that fracture for any type of swelling. Make sure that their uh, nerve processes are still there, that they're not having any changes in color, temperature, and sensation. We'll talk about the 6 Ps in this particular lecture, as well as in lab, talking about compartment syndrome. We need to be monitoring them for swelling that exceeds the pressure to the point where the blood vessels or the nerves are being compressed. And if they have neurovascular impairment, that is a quick phone call. We want to get that taken care of and get it remedied. Of course, we want to get them to elevate in the ice as much as possible. Watch for the swelling, watch for the pinkness of the toes instead of blue. Make sure that they still have a good pulse. We're going to encourage them to do their therapy, to do their exercise, make sure that they get adequate nutritional support. We provide the psychosocial care and provide some emotional support as well, because being limited can be depressing. Involve their family members and loved ones in their care and planning, especially as they've lost their independence. You're going to do some teaching to help them get home, make sure that they're caring for themselves, that they have pins and external fixator devices holding that leg to get them in. They've got a lot of teaching that we have to do. If they have a cast, we have to tell them about cast care, keeping it dry, making sure it's not wearing, that they're not having swelling, to elevate as much as possible, and to ice as directed, 20 minutes on, 20 minutes off, etc. Pin care, again, if they have uh, fracture that they feel that cannot be casted, that it needs to have a little bit more rigidity with the bones or moving bones back into place, then they may put some screws and some pins into the bone in order to well approximate those bones better, and then put them in a device that holds that all into place. It was our responsibility as nurses then clean those pin cares and to teach the patient how to do that. We may use chlorhexidine, which is a good antibiotic type or antimicrobial type soap. We'll use whatever the doctor tells us to use. Sometimes they used to use a lot of hydrogen peroxide. We're getting away from that a little bit more. The sterile water, sterile saline is still maybe used. We'll want to dry the area. Apply gauze if the doctor is saying to keep the pins still covered. Eventually, they will have those pins open to air. These people are usually in these devices for a few months as that leg or that arm heals, as that bone heals. We're going to maintain strict aseptic technique while we're taking care of the pins, and then tell the patient how to do that pin care as well for home. There's some really good videos out there from the different companies that make these devices for use that have on how to take care of pin care, so we can show that to the patient. We're going to document and record the pin sites and make sure that there's no redness, no pus, no exudate that we're seeing that is of concern. We're going to watch them carefully to make sure that the nervous system, that they're not getting any paresthesia, any paralysis, that the color of the foot is still good, that there's not extra warmth or changes in warmth, and that the pulses are, of course, make sure the pulses are intact, because that can change, especially with really bad swelling. Some of these patients will have casts. We have fiberglass casts, we have cast boots, we have splints, we have different types of immobilization devices. If this person is in a cast that's made of plaster, then they need to have, we have to take care that we're not digging our fingers into that wet plaster, because if you have a dent on the towards the skin, it's going to be on the inside too, rubbing on the skin, so we can have some skin breakdown. We use the palms of our hands, and of course we want to place plaster casts upon pillows, allow them to dry evenly. It takes really and truly, you may think it's hard, but it usually takes about a day or so, up to 2 days, for that plaster cast to really get completely well solid. Fiberglass is much more fast. It actually feels warm as it's beginning to dry. It gets a little bit warm as it's heating. Make sure you're elevating, that we're icing down that person's arm. They have used hair dryers for helping speed, or fans to help speed the drying of the cast. If we're using hair dryers to dry out the inside of the cast because it's damp, do it on cool setting or warm, never hot, because you're going to burn the patient if you use hot. Make sure that they know not to use a hot hair dryer. That they should watch for swelling of the toes, purpling of their distal fingers or toes, depending on if it's a cast on the arm or the leg. They need to assess how their fingers and toes are moving. Make sure that the pad that's around the cast is still providing some coverage, so that they don't have any sharp edges that can hurt the skin. If you need to, you can add moleskin or tape or lamb's wool to the area of the cast in order to pad that more. Again, elevate, ice, turn the patient, watch for any type of signs and symptoms of compartment syndrome, and document everything that you've done with that patient and that you've done that teaching. Again, elevation, positioning, cast care. Keep the cast clean, dry. This is the teaching that we're going to give that patient. Avoid inserting objects under the cast to scratch. No sharp objects in that cast, please. Again, protect the cast edges. Check your circulation often. Make sure your fingers or toes are nice and pink and not having any numbness or tingling, that there's no discoloration, that you have no sudden increase in pain. You want to continue to be mobile, and so you want to encourage uh, range of motion, upper body or lower body, depending on which area. If they have a broken leg, we want to make sure they keep their upper body mobile and that they're doing their exercises and keeping their deep breathing, etc. We want to teach them signs and symptoms of when they need medical attention exactly, with increased excruciating pain that changes, swelling that will not go down. If there's a smell or odor, if they feel pressure, definitely need to help them with their hygiene and ideas on how to keep hygiene, because they have to keep that cast dry and waterproof. There are some covers, but they still may get that cast a little bit damp. If they do get it damp, use again the hair dryer on cool setting in order to help dry that out. If it gets too wet, they need to let the doctor know. Uh, Provide ice packs for the first 24 to 48 hours to reduce the swelling if appropriate, etc. So we're going to make sure they have everything they need when they go home, because they're not going to be in the hospital while that heals. It takes too long. These patients, that if they have a cast or if they have a sprain of the arm, they're going to get a sling of some sort. If they have neck issues, don't use the type of sling that goes around the neck. Make sure you get you get the kind that goes across the shoulder, but not around the neck. Complications of fracture. Again, we've talked a little bit about compartment syndrome. We'll talk more about that in lab. It's caused by arterial vessel compression, or blood not getting distal to where the swelling is occurring. So is that reduced blood supply. It can also press upon the nerves, and if they have numbness and tingling, and then eventually paralysis, then we know that we got a big issue. We should be checking that out. If you see swelling and it's not going down, I would let the doctor know. And it may result from a tight cast. It could be that they just had an injury. They fell off a ladder and their leg is swollen. They could still get compartment syndrome without a cast or without any type of splinting. So it can happen because of the swelling has exceeded the ability within the muscles compartment to allow it to stretch. The fascia sometimes does not allow the muscle to stretch. So it exceeds that capacity, then we're going to have compression on the arterial sources as well as the arteries, veins, and nerve areas. These patients are going to be at a higher chance of venous thromboembolism, so we have to watch them for any type of blood clots, etc. Make sure that they keep moving. If they need blood thinners, they should be on blood thinners. If you have a long bone, such as a femur, tibia, humerus fracture, there's a possibility of getting a fat embolus that goes through the bone, into the marrow, into the blood system. Fat embolus can travel just like a clot would travel up to the brain. It can go through the heart, or it can go into the lungs. If it goes through the lungs, they'll have tachypnea, which is that fast breathing. They may just have dyspnea, some hypoxia. They'll have crackles and wheezes in the lung. They'll feel like they're just not able to catch their breath. You may even see petechiae, which is those little bitty red dots and stuff on the chest and neck. And it may appear also in the conjunctiva of the eye within 28 hours after the injury. But we want to catch that sooner. I actually had a 20-year-old that had broken a femur, and I remember the history. He was in surgery, had the femur fracture fixed, was up into the ICU, and was told later that he had had a fat embolus, and it killed him. It went to his lungs, and before they could get him intubated, before they could get him taken care of, he died. And so that always will remain in my memory. Osteomyelitis is an infection of the bone. It can occur because, especially with those open bone or compound fractures where we have a bone that's sticking out. It can also happen when it's a fracture that does not, because of whatever else bacteria will travel to that area of injury. We have the redness, the inflammation, we have heat, we have proper culture area for bacteria, and if the person ends up with that, we need to be watching that. It's a long-term treatment with antibiotics. The symptoms include pain, especially along with that bone and tenderness, redness, fever, and weakness. Delayed union is just as it would say, that is when the bone will not heal. It doesn't heal correctly, or it does not heal quickly enough, and sometimes that's due to a person smoking, it can be due to lack of oxygen or nutrition to the area. So it's important that we're teaching nutrition, don't smoke, and to make certain that they're taking care of their diabetes, et cetera, et cetera. Venous thromboembolism, again, I can't stress enough that blood clots, DVTs, PEs do form when the person is immobile, and especially you'll see them sometimes when they do have fractures. So kind of watch for that. Compartment syndrome, here's an example of compartment syndrome. You see the bruising in the ankle where they've had the injury, and now the toes are a little dusky. Again, they're going into surgery in order to relieve that pressure, and it takes a surgical procedure, what they call a fasciotomy, in order to relieve that. So in lab, you'll get the pleasure of seeing a fasciotomy. I do have a procedure, and I'll show you that when we have the 4 hours of lab. Again, here's compartment syndrome. Here's your pain on passive stretch, paresthesia, paralysis, pulselessness, and poikilothermia. Paresthesia, that's that numbness, that tingling that occurs. Paralysis, not being able to move the arm or the leg. Pulselessness, no pulse, or the lack of pulse, or the pulse is very hard to feel. Poikilothermia, they just wanted to add to the P's. That was the only word they could find that also meant change in temperature. So poikilothermia is a change of temperature. Testing that we will do in order to determine if this person has a compartment syndrome, most of the time is clinical presentation. We see this, we know that the pulses are limited, we see the swelling, we can't get the swelling down. So typically it's just done on clinical examination, but they can also do intercompartmental pressure measurements by using a needle device that they put in that can measure the pressure readings. If it's above 30 to 45 millimeters of mercury, it can indicate that that is compartment syndrome. They can also use near-infrared spectroscopy, or NIRS, which is a non-invasive way to measure tissue oxygenation. If there's less tissue in an area that we know that oxygen is not getting to that area, that also may indicate compartment syndrome. We can also use ultrasound to show if the blood flow is being inhibited. We can visualize, again, the swelling around the tissue. MRI, CT scan will also show us that swelling. And we can do a serum creatinine kinase, because that will tell us if there's muscle damage, if it's elevated. Compartment syndrome nursing care, regular neurovascular assessments. Meaning we're checking to make sure that they can feel. Can you feel me touch your toes? Can you wiggle your toes? Do they have movement? Doing pain management, because they're going to end up having more pain, especially if they have sudden increases in pain. We do the passive stretching. They stretch that arm, they stretch that leg, and they have increased pain that they can't hardly tell. It hurts so bad. We want to keep them elevated. If they have compartment syndrome, we keep the limit heart level, not elevated at that point. We're going to avoid putting cold compresses on them because of vasoconstriction, because we don't want the blood flow to be limited anymore once we have compartment syndrome. Before compartment syndrome, we're trying to get the swelling down. After we know we have that, we want to keep the temperature a little bit more regular. We don't want it to get cold, because cold limits, again, oxygen. Loosen tight dressings or casts. They may bivalve the cast or split the cast in order to try to alleviate swelling. And report immediately. Don't wait for late signs. If by the time you see lack of pulses or paralysis, those are late. That means you should have noticed that the colors of the toe and the swelling of the toe and the temperature long before there was no pulse. Be prepared for potential interventions such as surgery. Make sure that you end up, in NPO, pull the water, pull the food, because they may need to take them to surgery immediately. Explain to the patient the condition. They will get their consents. They'll tell them why they're needing to test. Accurately record all assessments, phone calls, everything that you've done in order to assist this patient. And then, of course, keeping in contact with the healthcare team, talking to them about what's going on. Here again is compartment syndrome, the surgical treatment. And again, as you can see here, this is a leg that they're showing a cross section with. And as you can see, there's the blue, the pink, and the green, the different muscle groups. So that's the anterior compartment, the posterior, and then you have the central or deep area. Each of those areas have their own fasciotomy that's holding onto the muscle groups, and they will have to do a splitting of that fascia, as you can see in the pictures below. We have the medial view here showing them going in and releasing. Here they're actually cutting the fascia. That's that whitish elastic fiber that holds those muscle striations together. So that's what they're releasing. We'll show you one of those in lab. Compartment syndrome can also occur because of infiltration of IV fluids. So be very cognizant, be very aware that when you have a patient that has swelling from IV and is real exceeding that skin, the skin is tight and there's no, they're having difficulty feeling their fingers, they've got numbness, tingling, the fingers are turning purple. That is also a form of compartment syndrome. So make sure that we're treating them for phlebitis, that we're going to end up stopping that IV immediately. We're going to get them elevated. We're going to talk to the doctor. We're going to let him know what's going on. It is very important that this tightness doesn't go away when it's compartment syndrome. It just stays there, and it gets worse over time. You need to make certain that the doctors are checking this out. And if the patient cannot bend their hand, cannot move their fingers, we've definitely got a problem. Again, the warning signs include severe worsening pain out of proportion to the injury, swelling and tightness of the limb, inability to move the hand, inability to move the fingers, weak or absent pulses, and that is a surgical emergency. Delays in that diagnosis can result in irreversible damage, and that becomes medical malpractice. So you've got to monitor your IV sites adequate, make sure that you recognize and act upon clear signs of infiltration, make sure you get that IV out, stop that fluid, and then get that hand up, get it treated, and then start treating get your orders for phlebitis. It can, if it's not treated, it can result in permanent disability and loss of their limb and ability to use it. Okay, hip arthroplasty. Let's just change our focus here. We're talking about hip and knee total surgeries. It's commonly performed with arthritis. It involves the head of the femur and the acetabulum, which is the joint where the ball of the femur fits into. They may have a hemiarthroplasty where they're just replacing the ball joint that goes down the stem of the femur, or they may have to replace both the acetabulum and the stem. We're going to, of course, these patients have known that they've had some issues with their hips for some time. After they've had hip replacement, there is some teaching that we must do and some orientation with our patients. We need to make certain these patients are coughing, turning, making sure that they're deep breathing, that they're leaving what they call a hip abductor between the pillow, between their knees, because they need to keep their limbs from adducting, meaning too close to the knees. We don't want the knees to touch after surgery. We want to keep those hips abducted for at least a day or two while they're sleeping, because if they adduct the hip, meaning they're coming closer, and they internally rotate that foot towards the opposite foot, they can then pop that hip out of its joint. And you will know that that has happened because they're going to have severe pain suddenly, and one leg is going to be shorter. That surgical leg is going to be shorter, and the foot is not going to be turned where it's supposed to be. So kind of watch for that. You'll see a little bit of a bump up there towards the hip. So that typically can occur if the patient is sitting too low. They need to make certain that they are using a toilet riser and higher chairs, not to sit on low chairs. So they want to make certain that they're in proper alignment, make sure that they, of course, do their therapy. Again, hip replacement also increases the risk of DVT. So a lot of these patients will be on blood thinners. They may be on Eliquis or rivaroxaban for a little while or warfarin, and then they take them off that app once they get to moving and once they're back mobile again. So it depends on the doc. Look for reactions to the cement. There may be signs of phlebitis edema or erythema because some patients may have a reaction to the cement that was used in order to glue that joint into place. Knee surgery, same issues, but it is exceedingly painful. As you can see, the sign on the left is the picture on the left shows the damage of the bone surface, the loss of cartilage, and then they're going to replace that by cutting off the top and the bottom of the feet, top of the tibia, bottom of the femur, and they're going to put a stem on the plate of the tibia and then a nice round surface over the end of the femur and a spacer to mimic the cartilage and stuff so the person can have continued movement. So administer their pain medications, assess for pain levels regularly. Definitely before they go to therapy, they should be assessed 30 minutes to 45 minutes before going to therapy. If they're sent home and they're going to be going to therapy, outpatient therapy, they need to be told not to drive. Let someone else drive them to therapy and to make certain that they're getting their pain medication before they do that so that they can participate in therapy. To take their walker and their crutch or their cane as they're told and instructed to by the therapist. Wound care, again, signs and symptoms of infection, making sure that the dressings are changed as told. The first few hours after surgery, ice will be applied in order to keep down swelling. They'll be elevating the limb. They will be told not to put their leg or their knee with pillows underneath it because that is not good. They want to keep that leg straight so that they can keep the flexibility and extension in the knee. And then, of course, doing their home exercise program to collaborate, make sure that they're getting good nutrition and that they're taking their meds as directed. About 6 to 8 weeks later, they'll be feeling pretty good. And a lot of times these patients can return back to work within that period of time, 8 to 10 weeks max. Spinal cord injuries. Okay, extremely important to understand spinal cord shock, spinal cord injuries, and when the nerves are being pressed at the spinal cord and what symptoms that patient may demonstrate if they're having spinal impairment. So any traumatic disruption of the spinal cord, it can be concerning. And of course, there's the spinal cord goes from brain all the way down towards the thoracic area. Then we have spinal nerves that then uh, come off those areas, go through the vertebrae, and then innervate different areas of our legs, arms, etc. And the higher the injury, the more deficit you will see below the injury. So if they have a complete spinal cord injury to the cervical spine, depending on the level, they could be a quadriplegic, meaning they can't move their arms or their legs. They may even not be able to breathe. If they have a spinal cord injury in the thoracic or lumbar spine, and it could result in some level of paraplegia. The higher the injury, the greater extent of dysfunction. Okay? 80% of these spinal cord injuries involve men. It's mostly also due to automobile accidents, falls, and of course, violence in sports. We're going to be doing some symptom collection. We're going to note for signs for paralysis below the level of injury, loss of bowel and bladder control. I'm going to stress that once more, loss of bowel and bladder control. They may present and not have any of this, but as the swelling around the cord intensifies where the injury occurred, they could actually lose bowel or bladder. If that happens, you tell that patient to get back to the hospital. That may mean that the nerves are being pressed on pretty bad. Okay, our care is to look at their respiratory, make sure that we're monitoring their ventilation and oxygen. If they're having more respiratory issues, especially as they're with mobility or movement and they're getting more short of breath, then we're going to be concerned, because the higher the level of the cord is being affected, that's being disrupted, then it could affect their breathing. They may have to be ventilated. They may have to have a tracheostomy. Skin integrity is very important. Make sure that we're relieving their pressure. Make sure that we're uh, appropriately positioning them, that we're turning them on their turning schedule, but making sure that their body stays in a proper body alignment. Again, monitoring for bowel and bladder management, making sure that we're teaching self-catheterization when those patients have that issue. Again, it takes nerves impacting the bladder for the bladder to empty. It takes nerves impacting the anus for the anus to be able to work. So they could have bowel or bladder issues. Proper nutrition, again, is always helpful. Hydration, making sure that we watch for swallowing difficulties, especially in high cervical injuries. Assist with your range of motion, implement proper prevention to, positioning to prevent complications and skin breakdown. Teach their transferring techniques, work with the therapist, assess for pain, provide support and encouragement, and teaching the patient about spinal cord injury and its management, as well as the family. Uh, Complications with spinal cord injury includes monitoring for autonomic dysreflexia. That is where the system, where the nerves and inflammation affects that because of swelling later. Deep vein thrombosis, pressure ulcers, um, and again, collaboration and keeping in communication with the care team is very important. Amputations. Okay, we've talked about amputations a little bit. They can occur in any extremity, and there's different severities. It could be from just a toe or a finger all the way to the disarticulation of the entire extremity. And depending on where the amputation occurs, the nerve endings still think that they're still there. That's called phantom pain. Because again, the brain is used to interpreting that nerve pathway as being the fingers, the hands, the arms, the legs, the foot. That nerve pathway is still there higher up, therefore the brain is going to interpret that extremity is still there. They can actually feel the pain in the amputated part for years. And unfortunately, it cannot be controlled with conventional methods. It can be controlled with like TENS or electrical stimulation or electrodes that they surgically implant. Think critically what conditions might involve chronic pain and what might cause acute pain. So recognize our cues with our patient. So pain is whatever the patient is experiencing. But again, if that extremity is not there, our tendency is to say, well, there's nothing there. But yeah, there still is. There's still those pain pathways. Preoperative care, we're going to reinforce information for the reasons for the amputation, discuss the proposed prosthesis and mobility training program. They're not going to get a prosthesis right away. They're going to wait for the healing of that area to make sure the incision area and the skin area has no swelling, that the stump of the amputated area is shrunk before they actually apply a prosthesis. Now, for our part, after they've had surgery, we're going to monitor them for signs of infection, complications, make sure that they bandages are applied as appropriate, that we're doing good skin care, that we're repositioning the residual limb properly to prevent fractures. We want to make sure that the leg is extended. If it's below the knee, we don't want that knee, tightening up or flexing too much so that they can have a good prosthetic result. Teach them about wound care, teach them about signs of infection, and then, of course, provide psychosocial and psychological support, encourage expression of their feelings, uh, help with the family, help the family be able to care for the patient. And then again, this is a long term, it's going to be the rest of their life thing. They need to be able to understand that there may be some limitations. Some of these folks don't have any limitation after they get their prosthesis. You see them running in the Olympics, but it's whatever they feel that they can do, that they are still a valuable person, even though they have loss of a limb. That and monitor them for depression, monitor them for the need to uh, be in therapy, etc. Implement fall strategies to prevent falls and also to help them with hygiene and care. Some of our patients will be in traction. There's a number of tractions that are out there. They can have traction that alleviates lower back spasms. They can have traction that is actually part of the healing of the bone fracture or the leg fracture, the hip fracture, wherever it goes. Do know that there is one where it's wrapped around the legs like a cast. It's different types of uh, Velcro and pulleys pulling that leg. It's called Buck's traction. Sometimes there's a question still on the NCLEX as well as the HESI about, name this type of traction. So we'll discuss that in lab. We'll show you some different kinds of traction. The most important thing is to document your interventions, to use other people to help you move this person, maintain the weight as the doctor has prescribed. Don't take the weights off unless the doc tells you. Don't make sure the patient's body weight is being managed and turned a little bit to get them off the dependent areas, but they still need to stay in proper um, weight restrictions on that extremity, etc. Teach the family and significant others that they're not to tamper with the traction device, ropes, or weights. Crutches, we're going to go over crutches in the lab, but the basic thoughts about crutches is that yes, we need to make sure that they're not putting their arms um, on the upper cushions. Those upper cushions are not for their axilla. That's actually just there to be under. They should be putting their weight on the hand grips. Crutches should have 2 to 3 fingers width below the armpit. The hand grip should be at a 15 to 30 degree elbow flexion. Canes should be at the top of the trochanter or at the bend of the wrist. So it's at the proper, everything is about 15 to 30 degrees for the grips for crutches, canes, and walker. That's the appropriate uh, degrees of flexion in the elbow to allow for good strength. Teach safe technique is something I can't really talk about and give you verbal cues for that particular crutch and cane, but we'll get the chance to put hands on crutches and canes in lab if you've not already done that. Gait training should be done on a level surface. We do, if they have stairs that they need to navigate, we need to teach them how to navigate using um, their assisted device, whether it's the crutch or the cane. Walkers should not probably be on stairs. Um, People have fallen off the stairs using walkers because the stairs are not wide enough to support that walker. They need to find a different way of getting up and down those stairs. Clear pathways ensure that there's no slip rugs, that rugs are removed that slip easily. Make sure that they have good footwear and that they're watching for skin irritation, padding areas if necessary. Continuing to do upper body strength exercises because they need to have good upper body strength to use crutches and the walker as well as the cane. Make sure that they're using the cane and strong arm and that it's moving with the weak leg. So meaning that if their weak leg is weak on the left side, they should have the cane on the right using it with the right hand, and that right hand and left leg moves together for support. If it's the right leg that's the weak leg, then the cane needs to be held in the left hand. So make sure your patients are using their canes correctly. A lot of them don't. Walker training, definitely they need to have a walker that is at the right height. Again, it should be at the crease of their elbow or at the higher point of the trocar, the trochanter of the femur. Again, 15 to 30-degree angle with their elbows. They should be walking into the walker, not pushing the walker in front of them. They need to keep their head erect and their eyes straight forward. So the proper technique is to hold onto the hand grips, to move the walker, and then using their weaker legs step into the walker where the walker's legs are. And they should start with their feet even with the back, but when they're moving forward, they should step in. So again, they should be driving that walker and walking into it instead of pushing it in front of them. Again, don't use walkers on stairs. It's not safe. Ensure clear pathways. Make sure that the feet of the walker is still able to glide. If it's not gliding well, sometimes the glides that are on the walker that are provided aren't sufficient. Sometimes they'll put tennis balls on the back legs so that they scoot and move easily. Common medications for mobility problems, again, Tylenol, Narco. Remember, Narco is a Schedule 2, as well as Percocet, a Schedule 2 opioid that can cause constipation. So if these patients are on any type of narcotic, assess them for constipation. Make sure that we're giving them stool softeners and laxatives as needed. Typically, if they're having an acute injury, they're only going to get a small 7 days from the emergency room of Narco or Percocet. If they're taking a narcotic, they're also going to probably give them a prescription for Narcan for reversal just in case. So make sure that you're assessing them for side effects of drowsiness, dizziness, respiratory depression, especially if they're overtaking. Any nausea, vomiting, again, we talked about constipation, and the risk of dependence and addiction for long-term taking. Also understand that Narco and Percocet also includes acetaminophen or Tylenol component. Got to make certain that we're not over giving them too much Tylenol. And again, oxycodone, Narco, all of these do have drowsiness, dizziness, et cetera, and liver toxicity is a problem because of the acetaminophen. The maximum dose for acetaminophen in 24 hours is what? Okay, you should have said 4,000 milligrams. If they have liver failure or liver issues, they're going to be reduced. It might be 2,000, 3,000, or 35, depending on what the doctor is limited. Here's your NCLEX practice questions. I'm going to go ahead and go through these real quick. LPN caring for a patient with recent spinal cord injury should prioritize which of the following interventions? And I can see that we have some multiple letters here. Oh, let's go back. It's not going to give me the answers here. Anyway, monitor for signs of autonomic dysreflexia. Definitely is the number one. All the interventions are important, but autonomic dysreflexia is the highest priority for the LPN because it's life-threatening. That can occur in patients with spinal cord injury levels of thoracic level 6, which seems to be kind of low, all the way up above to the C1 area, or C2, of course. It involves a sudden, uncontrolled sympathetic response to stimuli below the level of injury, leading to dangerous spikes of blood pressure, etc. So if we see the patient has had normal blood pressures, now they have 180 over 110, they have sudden onset of severe headache, flushing, sweating above the level of injury, pale coolness below the level of injury, bradycardia, nasal congestion, blurred vision. Yes, this is all parts of the autonomic dysreflexia. meaning their autonomic system is not reacting correctly. Which of the following is the earliest objective clinical finding in compartment syndrome? Pulselessness, paralysis, paresthesia, and pressure or tense feeling in the affected compartment, that's with stretch, are all important. But the earliest associated symptom is typically D, pressure or intense feeling in the affected compartment. That happens early. That's because all of a sudden we see an increase in their pain. They've been having good pain control, and suddenly they don't. Um, and when they stretch their arm or their leg, wherever the injury is, they have intense pressure and intense pain. Late findings of compartment syndrome is that paralysis, and then right before that is pulselessness, and it may be pins and needles or paresthesia. Which of the following is not a classic symptom of Parkinson's disease? And we haven't talked about Parkinson's disease quite often here. The acronym for this, for Parkinson's disease, is TRAP. So remember the acronym TRAP, T-R-A-P, which is tremor at rest, rigidity, akinesia or bradykinesia, and postural instability. So we see all of those. So that means, oh, bradykinesia, okay, that's part of it. Rigidity, oh, that's part of it. Tremor at rest, oh yeah, that's part of it. It's memory loss. So D is not part of the typical or often seen symptom of Parkinson's. Now they may have later on have some issues with hallucinations and things like that, but that's part of the later onset. Okay. A patient with a femur fracture tells a nurse, "I feel useless. I can't do anything for myself anymore." Which of the following is the most therapeutic response by the nurse? So remember your communications. From the communication, therapeutic communications cues. Option A dismisses the patient's feelings and may be unrealistic. Oh, you'll be back on your feet. Well, okay, no. C normalizes the experience, doesn't actively address the patient's concerns. Well, of course, everybody feels this way. It's normal to be frustrated. Okay. In other words, I just don't want to hear you. B contradicts the patient's statement, which makes them feel misunderstood. Really and truly, B is probably the better answer. It's the most therapeutic response because it acknowledges the patient's feelings and redirects his focus to a positive capacity. So it just says, okay, I understand how you feel, but let's see what we can focus on what you can do and see if we can get you to be more active. Which of the following is not a risk factor for osteoporosis? A risk factor is a cause. So we're looking for those that are possibly, yeah, the inflammatory bowel disease may exist with osteoporosis. Low testosterone in men, that can be a risk factor for developing osteoporosis, and long-term corticosteroid use can also result in bone loss. It's regular weight bearing. Actually, regular weight bearing exercise increases our bone. It builds the bone. So that would be the proper answer. B is in boy. Which of the following is not a typical symptom of osteoarthritis? Morning stiffness lasting more than 30 minutes is not atypical. Usually they are stiffer in the morning. but it doesn't last that long. Usually they can get up and start moving around and it actually resolves quickly. Um, they may have crepitation, which is that grinding of the bone. They may have pain that improves with rest. So in the early stages. So here's a case study for you. Mrs. Johnson's hip fracture. Okay, Mrs. Johnson is admitted to the orthopedic unit after falling at home and sustaining a hip fracture. She underwent open reduction and internal fixation. That's that nailing of that hip, okay, or they actually fixed all that fracture. So her vital signs she comes up with is 130/80, 82 heart rate, respirations are 18, and temp 37.2. Pain is at 6 out of 10. Surgical dressing is clean and dry, and the affected leg is slightly edematous, meaning it's slightly swollen. So our interventions for our patient, I really would like for you to have seen this. So let me see here. Let me see if I can't pull this over. Yeah, we can do this. There you go. So some of our interventions. There's our information for the patient. So here's some of our intervention for this patient. We're going to monitor their vital signs every 4 hours. Think about these, see if you come up with any others. We're going to assess their pain regularly. We're going to prescribe their analgesics or pain meds. Definitely perform neurovascular checks on the affected limb, making sure that they're feeling their toes, that the pulses are intact, that they're not having any increased pain in the calf, which would indicate a DVT or a blood clot. We want to elevate the affected leg to reduce edema, make sure that we're giving some ice if that's what the doctor has ordered, that ice should not be applied for more than 20 minutes on, 20 minutes off. Make sure the ice is wrapped in a pillow or a towel. Encourage them to deep breathe, make sure they're doing their incentive spirometry. And then, of course, proper body alignment and then turning every 2 hours. Make sure that they're encouraged to go to therapy. We should be going in and finding out when therapy is coming. If they're coming, let's say, 30 minutes or so, that would be a good time for us to make sure if they're due for the pain meds to get those on board so that they're in as good control as they can so they can have good participation. So what are your care plan goals? Pain management, prevention of complications such as DVT, early mobilization and education, of course, and getting that patient ready for discharge. Make sure you're documenting your education and discussing, how to keep that patient involved in their care. Okay, so that was Mrs. Johnson. Here's Mrs. Steins. Okay, this one here is, let's see what this one was about. Okay, this is also hip fracture recovery. She's on day 2 post-op. She's reluctant to move due to pain and fear of falling, slides in bed while protecting hip, slightly diaphoretic on movement, and she's short of breath. Drainage down of her left hip area, etc. So let's take a look at her. She has type 2 diabetes. So we're going to make sure that we're prescribing pain medications, monitor the site for signs of infection. I would be looking at her most recent labs, see if her white blood cell count, make sure that they're not elevated. Look at that dressing, make sure that there's no redness, etc. Make sure that the drainage is normal. We would expect still a little bit of serous sanguine, a little bit of peepish drainage with that, but nothing purulent. We want to make sure that if she had staples or if she had any type of surgery, that they're well even, that there's nothing missing, that there's no redness, etc., or oozing when we're doing the dressing change. And we can address her fear of falling. So to kind of discuss between yourselves what would be, how would you help this woman so that she wouldn't feel like make sure that she's asking for assistance, make sure we have a walker, and that she's actually maybe bring therapy in to talk about this so that we can ensure her that with her continued that if she's not moving, she's going to get weaker. So we want to make sure that we're increasing her mobility and her independence. So think about this. These are real patients. Sometimes, these are the things that we run into. I appreciate your attention today, and I thank you very much for the time that you've spent with me. And if you have any other further questions or concerns, let us know. It looks like this is going to take about an hour and 20 minutes to finish, and so I'll give you back a little bit of your time.